Good day, everyone, and very welcome to this very first HELIConference webinar, which will give you some initial insights in the burden of post-COVID conditions in Belgium. My name is Brecht de Vleeschouwer, and I'm an epidemiologist at CNSano, the Belgian Institute for Health, and I'm also coordinator of the HELICON project, which aims to quantify the wider health impacts of the COVID crisis in Belgium. One of the additional activities or objectives of our project, which is supported by BELSPO, is also to give insights in the current evidence on the COVID crisis in Belgium. And it's in this context that we will be organizing on a regular basis webinars where we will invite speakers from across the country to present some current insights, activities, and new projects. So today we have the honor to have different speakers who will give us insights on the burden of post-COVID conditions in Belgium, talking about current insights, but also future perspectives. We will start with a presentation by Dr. Diego Castañares from the Healthcare Knowledge Center, who will talk about insights from a recent literature study that the KCE has performed on COVID-19 long-term consequences. Afterwards, we will have Professor Philippe Beutels from Antwerp University, who will talk about the Great Corona Study and what it can tell us about long COVID conditions. And finally, we will have Dr. Pierre Smit from our institute, who will give us some initial insights in the COVIMPACT Study, one of the studies at CNSano, which aims to actively characterize the physical, mental, and social implications of long COVID. The meeting or the webinar will be closed by Anne Lee from the Flemish post-COVID community, who will give us some closing remarks and will remind us why this scientific research on long COVID is very important. During the webinar, we will ask everyone to keep their microphones and videos switched off so that we can focus on the speakers. After each presentation, there will be some time for questions and answers. And for this, you can use the chat box or the Q&A box in WebEx, or you can also raise your hand and ask the floor and ask your question directly to the speakers. So, having said that, also note that after the webinar, the slides and recordings will become available via our website. So having said that, without further ado, I want to now give the floor to our first speaker, Dr. Diego Castañares from the Belgian Healthcare Knowledge Center. So Diego, the floor is all yours.
Thank you, Brecht. Sharing my slides. Can you see my slides?
We see the presenter mode. So if you would click on display settings at the top.
Yes, yes.
Then you can switch, the first one, swap presenter view and slideshow. Yeah, perfect. Thank you.
Okay, thank you. First, I would like to thank CNSano for having invited KCE to present this ongoing project on long COVID. So I'm Diego Castañares, and the principal investigator of this project at KCE is Koen van den Eede. Can move my slides. Yeah, okay. So as you certainly know, although most patients will recover within 2 weeks after COVID-19, there is no widespread recognition that some patients will experience some long-lasting symptoms. At the beginning, those complaints were overlooked or even dismissed by doctor, but now there is a worldwide recognition of long COVID. Last year in September, NICE in the UK proposed some definitions based on the time beyond disease onset. Ongoing symptomatic COVID-19 is for patients having symptoms for 4 to 12 weeks after infection, and post-COVID-19 syndrome for patients still with symptoms after 3 months. A puzzling feature of long COVID is that it can occur regardless of the acute severity of COVID-19 and independently of age. Children or young adults can be affected by long COVID. Long COVID adversely impacts daily life and represent societal and substantial burden. So I have difficulty to move my slides. I'm sorry. Okay. So in our case study, in the first part, we focused in a classical approach of a systematic review on epidemiology and pathophysiology of long COVID. We have already published preliminary reports, and the final report is expected this year in October. In the second part, we assessed the unmet needs of Belgian populations with long COVID through interviews and a survey conducted in Belgium with more than 1,000 patients. And the third part is the KCE webpage, in which you can find updated international literature. I propose this morning to share with you the preliminary results of pathophysiology of long COVID first, really briefly, and then on epidemiology. It's important to bear in mind that up to now, research on pathophysiology has mainly focused on acute COVID-19 and its severity. And papers on the pathophysiology of long COVID are still sparse. We made the distinction between two types of publication: pure hypothetical articles and studies including patient data through medical imaging, blood sample analysis, autopsy. I agree that autopsy is not really relevant for long COVID patients, but it can give some clues into its pathophysiology. Besides, in this study, a distinction was made between two categories of mechanisms. On one hand, you can have organ injury acquired at the early phase of infection, and on the other hand, you don't have any visible organ injury. So roughly, current literature proposed two types of mechanisms to explain long COVID symptoms. First, virus-driven tissue damage acquired at the early phase of infection, and then a dysregulated immune and inflammatory reaction in response to the first phase of infection that can give rise to multiple long-lasting disorders such as microcirculation disturbances, coagulation activation, autoimmunity, metabolic problems, or activation of fibrosis pathway. But it should be noted that all articles are really mainly hypothetical. So I can give you an example here of the current findings from studies involving long COVID patients. I'm not going to see into depth this table, but for example, for symptoms related to the central nervous system, studies have shown brain hypometabolism through PET-CT, for example, or even brain inflammation through magnetic resonance imaging. Those studies involving patients are very limited for the following reasons: small sample size, initial severity of symptoms are really variables. Symptoms can vary a lot, timing of inclusion also. And frequently, healthy volunteers are used as control group rather than short COVID patient. I would say that it would be better to include a patient who did not develop long COVID as control group in this kind of study. What about pathophysiology? Available evidence on prevalence of long COVID remain highly limited and insufficient to formulate really a sound conclusion. Why? As you can see on this graph, estimating the prevalence of long COVID is really difficult because studies are really heterogeneous. Why? Because first, you can have hospitalized patient or non-hospitalized patient during the acute phase of the illness. Red dots are for hospitalized patients and blue dots for non-hospitalized patients. Green dots are for studies mixing both types of patients. Second reason is that the follow-up time is can vary a lot. Frequently, there is no control group. Patient symptoms, are self-reported, and above all, there is no accepted universal definition, taking into account if there is or not a permanent organ damage. So we notice that there is a possible overlap of different issues. You can have symptoms specifically attributed to COVID-19, symptoms related to hospitalization or deconditioning consecutive to the severity of illness, even in ambulatory patients. You can have also an overlap with post-intensive care syndrome, PICS, which is quite different. And what about the worsening of pre-existing comorbidities or even different disease that could overlap with long COVID? According to the current literature, we can say that at least 10% of patients will present one or several symptoms, as you can see on this graph. Two remarks on this graph. It's easy to see that patients who were hospitalized at the acute phase of infection report higher prevalence of long COVID compared with patients who did not. And second remark, there is a decreasing trend over time. What are the symptoms? So symptoms can affect all organs and are really numerous. In this slides, symptoms highlighted in red are the most frequently reported symptoms. Fatigue, but not a simple fatigue, a disabling fatigue. Headache, neurocognitive problem called brain fog, that can be a real problem for professional work and daily life work. Also, dyspnea, shortness of breath. Dyspnea could be a good example to illustrate that you can have a symptom associated with organ injury or without organ injury. I mean that you can have dyspnea with an abnormal chest X-ray. For example, if the pneumonia was really severe, or if you were admitted to the intensive care unit with mechanical ventilation. But chest X-ray can be normal also. In this situation, there are other hypotheses. For example, a virus damage on the baroreceptor in your chest, baroreceptor that control the regulation of respiration and cardiac frequency during exercise, for example. What about the risk factor? Really easy slides. There is up to no reliable and sufficient evidence to claim some risk factor for long COVID. So you can feel a bit disappointed because so many studies with no sound conclusion, but limitations are numerous and should guide our further research. They are the following: lack of consistent definition of long COVID is really a problem. Heterogeneity of targeted population. The study design is highly variable, and there is also a high risk of bias, recruitment bias, recall bias, because symptoms are self-reported. And finally, an underestimation can occur also because patient can be asymptomatic at the acute phase of illness, or last year, patient at the first wave were non-tested. And finally, to sum up, I would say that majority of patients will recover from acute COVID-19, but about 10% of them will develop long-lasting and persisting symptoms due to organ damage or triggered by unknown mechanisms. Those symptoms can overlap with many other conditions and issues, but the impact on daily life is really a substantial burden. So this study will be just a piece along with other studies conducted in Belgium, and that will be present in this webinar. CACI launched last week a call for funding of long COVID management. Thank you for attention.
Yeah, thanks a lot, Diego, for giving this very important insight in the current knowledge, which is, of course, a bit disappointing because it mainly highlights all the uncertainties and question marks, but it also shows that there is indeed a strong need for projects such as the ones that you will be conducting within KCA and projects that will be conducted by the partner organizations. So hopefully if we redo the review in a couple of months, then we will be able to answer many of these questions. We have some time for questions and answers for discussion, so don't hesitate to type in your question in the chat box, or directly ask your question by unmuting yourself.
I can stop sharing maybe.
Yeah, thanks. Then we will see the cameras better.
Is it okay?
Yeah, perfect.
Yeah.
Maybe if I can start with one question, are there any specific plans to update this review on a regular basis? Because it's of course a domain where the knowledge keeps being developed and keeps moving. So what are the plans for updating this review over time?
So we are currently updating the review, and we began this review with a pragmatic review in January, and the final report will be updated for October. Our web page is also regularly updated for international literature.
Mm-hmm. Okay, thanks. We still have a few minutes for other questions, if there would be any. Yes, I see a question from Nico Speybroek from UC Louvain, claiming that you didn't mention indications for risk factors, while the ONS reported that women are 30% more likely to get post-COVID conditions than men, and that the age group 35 to 70 would be most affected. So did you come across this information from ONS, and would you think this is sufficiently reliable?
Yes, there are regular update of the ONS numbers. This is the more robust data up to now. So I completely agree with Nico Speybroek. Female gender could be a risk factor. We retrieve some studies with the same approximately same results that ONS, but I agree that ONS results are really robust.
Okay, thanks a lot. Maybe a final question. Would there be any way for the participants to this webinar to remain informed of the outcomes of your review? Probably by following the website, but maybe a more active way to stay informed about what will happen?
All reports, preliminary reports or final reports are published on KCE website. If you want to be regularly informed, you can follow by some social media, or write to Karine Rondia, and we can send you a mail when we have new results.
Okay,
so the mail of Karine Rondia is available on the KCE website, of course.
Yeah, we will also put the link in the chat later on. Okay. I see one more question. So one of our colleagues is saying that the participant in one of our studies has almost complete ageusia at 8 months after infection, and he's wondering if there are data on ageusia beyond 8 months or even 1 year after infection.
Yes, so there are many studies about taste and smell disorders. One of the problems with those studies is that they include only patients that developed such problems at the acute phase on infection. So determining prevalence is difficult, but practically to answer this question, there is quite good. There is a quite good evolution of taste and smell disorders over time. Some study reports that less than 10% of patients still have symptoms. So the big majority of patients will recover taste and smell disorders. Some with problems, but over time there is really an improvement.
Okay, perfect. Thanks a lot. Right, so thank you, and I believe we can now move on to our second speaker, which will be Professor Philippe Beutels from Antwerp University, who will introduce us to the Great Corona Study and what we can learn from this study. So Philippe, the floor is yours.
Thank you. I hope you can see my screen.
It's also the presenter view, so if you can click swap displays at the top.
No, I can't. Wait. Where do I have to click?
So yeah, you had it before. So if you click again to put it on full screen mode, then I saw an option. Yeah, so here I see the presenter view, and then at the top of the screen, I see end show tips, then swap display.
I don't see that.
Okay, that's
yeah, probably, yeah, I have it.
yeah,
That's at the other screen. Okay, sorry.
yeah, perfect. Now it's perfect. Thank you.
Okay, thanks. Yes, I'll talk briefly about the Great Corona Study, a few general characteristics first. So this is been going on 40 times now. We did one yesterday also. It's an open anonymous call. Each time people have to take part again with their and give their basic characteristics. So it's has both a cross-sectional and a longitudinal component in the sense that we do know or do ask of participants to indicate their frequency of previous participation. And this has changed over the waves as the number of waves accumulated, of course. At first, we did this weekly, every Tuesday, and so far we had more than 3 million completed surveys, more than 2,700 questions. And as mentioned by previous speaker, of course, self-selection bias is unavoidable in this type of design. We do use weighting to get representative corrections for age, gender, education, and province of residence. We are also providing a general background document that people can read if they want to know more about how we deal with different forms of bias and representation. One of the strengths of the Corona study is that we have a lot of participants. We've had in the first 7 waves more than 100,000 respondents. First 12 waves more than 50,000 in each wave, and since then about between 20 and 30,000 per wave. And the last 2 waves we've been going down, so the interest is going down a little bit. We're up to around 15,000 respondents. The age distribution has changed as participation is changing over time. But given the large number of participants, of course, we can correct for that. We do have overrepresentation from Flanders. So this is an example from wave 3, where you see the distribution across the country. We had in that wave over 400,000 respondents. And clearly most of those were in Flanders. And this has been the case in most waves, although we've tried to recruit as much as possible in Wallonia. And of course, this becomes more of a problem when the number of respondents is going down. per wave. But like I said, we're still at about 15,000 currently. So we have a broad range of themes. I'm not going into that. In terms of syndromic surveillance, this is something that's very much a work in progress, especially about long COVID. So that's a caveat I put up right in front. We've been trying to, so when we started doing these surveys, first one was launched 17th of March 2020. We wanted to make, to look at two things. So the prevalence of symptoms as well as behavioral change that occurs under the influence of interventions. And as you can see in this graph, this is showing people who are reporting at least two symptoms of a respiratory infection over time through the different waves by age. You can see this is being influenced by both seasonal aspects and, of course, behavioral change, which has strongly changed after the beginning of this registration in the survey. So we are still seeing symptoms as a consequence of behavior prior to the initial measures that were put in place in March 2020. We've published separately about this, and we're still working hard on how to make the most of this type of data because it's important, we think, also for pandemic preparedness in the future to be able to pick up signals very quickly and very early on. And we do see that the symptom reporting has had a predictive effect on the incidence, although limited but significant. And what is important is also the spatial resolution that you can obtain with this type of data to make good predictions. Now, so this is about symptoms over the last 10 days. That's pretty easy to collect in a way, and that's not the focus of today's talk, but I'm just mentioning this, that this is also changing. So the different symptoms that are reported is changing as well as the number of, or the percentage of respondents that report any symptom as the seasonality has its effect on different respiratory infections and behavior is changing. Now, if we look at, we started looking at having symptoms that were staying for a longer period. So people who had a positive test result more than 2 months prior to the survey, and they're reported still experiencing symptoms. We are trying to tap into that, and we started doing that in October 2020. This is later on, wave 36, where you can see an estimate of the percentage of respondents that fall into that category that still experience symptoms. And you can see there's a bit of an age gradient in 35 to about 70, having a higher propensity, but this is also subject to the different waves that we're looking at. And I apologize for some of the Dutch in these slides. As I mentioned, this is very much work in progress also. This is the symptoms that people are actually, the specific symptoms that they are reporting, and they think are related to their positive COVID diagnosis. So this people who test positive more than 2 months ago and experience symptoms. And you can see right at the top is general tiredness and memory problems, concentration problems, shortness of breath, and recurring headaches, confusion. Those kind of things appear very much at the top, and this is very consistent through different waves. It is also consistent when we look at how long ago the COVID diagnosis was. Although we see, for instance, for the loss or the reduction in ability to smell or taste, that there's a reverse aspect where if it's longer time ago, it seems to be reported more often, and there are a few more of those symptoms. And this is just to illustrate that in the different waves, we have recorded this, but that these top 5 symptoms are quite consistent across the waves. in general. Now, an important aspect in the design of this study is, as mentioned also previously, is the bias that occurs. And we are noticing that there is a change in the percentage of respondents that still experience symptoms when you look at it across the different waves by age. And we do think when we analyze these data, we do observe that one of the underlying reasons to report this type of symptoms is previous participation in the survey. So that's an indication for us that there is this self-selection bias, and that as the study comes on, we are attracting relatively more people who are experiencing symptoms. Of course, in the whole of the survey, this is a small group. When we look at this specific problem of continuing symptoms, that of course distorts the analysis. We've also been asking about whether or not people felt that they had an effect from their vaccination on the long-term symptoms. And been asking this quite recently. And of course, again, the list of clinical symptoms is quite general, self-reported, so these are weaknesses, but we do see some indication for shortness of breath, especially, and the loss of smell and taste, that those have been improving. So this is on the right hand bars in blue and greenish colors. On the left, you have the red bars indicating a worsening of symptoms. So there are people who are reporting worsening of these symptoms after vaccination, and others an improvement. And there seems to be more improvement related to shortness of breath than the worsening. But this is, of course, with a lot of caveats in how we are measuring this. So we're picking up signals, but it's very hard to put a specific quantification on these. We do see that there's an improvement reported more often by men, by people who are fully vaccinated. We do see a tendency, but we need still to be able to confirm this. And this, as I said, with a lot of caveats, work in progress, that there's a slightly larger effect from AstraZeneca as opposed to Pfizer's Johnson & Johnson. People who have had a positive C19 test have also a greater effect. So this was, we're looking at people who had a positive test result here, as well as people who didn't have a positive test result but did have long-term symptoms. And people in general younger also feel a better effect of improvement. So wrapping up, what I've been trying to convey here is that it's very hard to do this well in the survey design that we have. So the Corona study has many advantages, but to be able to quantify the prevalence of long COVID symptoms, that's very difficult. We currently estimate this to be 2 months after a positive test result at around 15 to 30%. And the most important covariate that we find is gender. So women have a higher chance of reporting it than men. And in some subgroups that we analyze, it's twice as many. So it's quite an important effect. The top 5 symptoms: tiredness, concentration problems, memory problems, shortness of breath, recurring headaches. So there is a limitation that I've been signaling about the design of the study to report symptoms, especially when there's a long recall period. And we see that the percentage of respondents with a positive test result over 2 months ago, indicating related lingering symptoms, is higher if they participated in previous waves of the survey. For these types of research questions, there's a need to set up a different design, we think, but we can use these types of design also through panels that we construct to try to estimate healthcare use and quality of life impairments in people who are affected in such a way, rather than estimating the exact percentage. For that, I think you need cohort studies So follow up a cohort of people that you start following up at the time that they first have their COVID test positive. And finally, I'll refer to the Infectieradar, which is exactly trying to collect data on healthcare use and quality of life impairment. So this is syndromic surveillance that we have started up, and we have taken this out for a large part out of the Corona study. And the Corona study will phase out, but our next survey is at the end of July. I'd just like to acknowledge that, as well as the EpiPost project, which this is also affiliated. So thank you for your attention.
Yeah, thanks a lot, Philippe. Thanks for sharing these preliminary results. And I would say, despite the limitations, they do provide an important piece of the puzzle. So the more information we can get, the better, of course. We have maybe time for one question from the audience. I see a question from Koen first. So he's saying a possible reason why symptoms after vaccination may improve among this younger male population is due to regression to the mean, spontaneous recovery, as these populations have less chance of developing persisting systems. Do you have any immediate thoughts on this remark, Philippe?
Yes, so that's indeed some of the things that we're trying to figure out more. I forgot to mention also, we have been constituting a control group within the Corona study, but we haven't done the analysis on that yet. So people who have not had a positive test but do have lingering symptoms that overlap with the long COVID symptoms. And we will try to correct for those kind of aspects as well.
Yeah, thanks, Philippe. I will move to the second person who asked the question. She's asking why this study is identified as a citizen science project. Where or how were citizens and patients involved apart from answering the survey questionnaires?
Because it's, I can see, it depends how you define citizen science in this aspect. I think we call it like that because anyone with access to the internet in some way can participate. And we're calling upon citizens to participate very regularly. And there's been massive participation at the very start. So that's why we're inclined to call it the citizen science project. But perhaps you can challenge that, whatever this definition you use.
Yeah, okay, thanks. I see some more questions popping up in the chat, but I would suggest that maybe Philippe, you can try to have a look at these and answer them in the chat directly, because we need to continue with our schedule to keep track of the timings. So the third presentation will be by our colleague Pierre Smit, who will present the COVIMPACT study. And this follows very nicely the previous presentation, because here the aim is to perform an active follow-up of individuals that tested positive for COVID. So Pierre, thanks for pulling up the slides, and the floor is yours.
Thanks a lot, Brecht. So hello, everyone. First of all, I would like to thank the colleagues of the HELICON project for organizing this very nice webinar. So I am very happy to present to you the COVIMPACT study organized in Cienzano on long COVID and its impact on physical, mental, and social health. So the COVIMPACT study has two main goals. The first goal is to study the long-term impact of a COVID-19 infection on physical, mental, and social health. And the second goal is to identify groups at risk and the factors that are associated over time with a favorable and unfavorable evolution. So there are two main stages in the design of the project. The first stage is to contact a potential participant, of course. So we are working with contact tracing centers and contact tracing agents proposed to anyone living in Belgium, age 18 and over, and with a recent COVID-19 infection to participate in the study. The second stage is to have a cohort of individuals with a diversity of profiles and also severity of COVID-19 cases who voluntarily agreed to be followed over time. And those participants will be recruited for 2 years. The final stage is the follow-up, of course. So each participant will receive a questionnaire by email every 3 months from the date of entry into the study. So participants who already entered at the start of the study will have a maximum of 9 data collection points, and those who enter at the end of the study will have a minimum of 2 collection points. So the study started 2 months ago. So the first participant was on April 29. So the first follow-up will be in 1 month, so 3 months after the entrance, so in July 29. So since the end of April, we already had more than 3,000 completed questionnaire with agreement to follow over time. So here in the graph, you can see the timeline of the project as well as the evolution of the size of the cohort for the last 2 months. So the project will last 2 years until April 2023. And the recruitment of participants in the cohort so began 2 months ago and will last until January 2023. And the follow-up of the first participant will begin in 1 month and will continue until the end of the project. So the goal of the COVIMPACT study is to have a global approach of the long-term consequences of COVID-19. So we will assess the impact of COVID-19 infection on physical health, quality of life, functioning, so daily activities, mental health, social life, and also on economic outcome. And we will also assess factors that are potentially associated with favorable and unfavorable evolution. So social demographic factors, the vaccination status of individuals, their health behaviors, their comorbidities, and also healthcare use during the follow-up. So for this presentation, I will focus on the first 2 indicators, physical health and quality of life. In terms of profile of the current cohorts, so the average age of participants is 41. We have 60% of women. Half of the participants had a high educational level. In terms of vaccination status, so 22% are vaccinated for COVID-19, and among them, 82% had 2 doses of vaccine. In terms of infection, on average, participants reported 6 different symptoms, and the most frequent one are headache, cough, muscle pain, and fatigue, and only 9% of the sample are asymptomatic. So now I will present the preliminary results on the situation before the COVID-19 infection in comparison to the situation in the days following the infection. So the first results are on change in shortness of breath following COVID-19 infection. So we use the Medical Research Council dyspnea scale to assess it. So on the left, you can see the prevalence in 3 dyspnea severity categories before and during COVID-19 infection. So individual with known or mild dyspnea, those with moderate dyspnea, and those with severe dyspnea. And you can see that the proportion of individual with no or mild dyspnea decreased following the infection, while the proportion in the other 2 categories increased. On the right, you can see the cross table of the same result. And what I would like to highlight here is that among individuals with no dyspnea before infection, 30% had moderate dyspnea during the infection. And among those with moderate dyspnea before infection, 10% had severe dyspnea during infection. So in terms of risk factors of worsening dyspnea following COVID-19 infection, our results already show that individuals with lower level of education were more likely to have worsening dyspnea, as well as those not having at least 1 dose of COVID-19 vaccine and those having a chronic respiratory disease before infection. Now I will present some results on change in quality of life following COVID-19 infection. So we assess quality of life using the EQ5D questionnaire to have a score ranging from 0, so very poor quality of life, to 100, very good quality of life. And you can just see here the score before infection, that was 87 out of 100, and that the score during infection in the cohort was 72. So we have an average decrease of minus 15 points following the infection. In the graph, you can see the proportion of individuals reporting a problem in the 5-dimension and quality of life. So the dots represent the situation before the infection, and the column, the situation during the infection. So the dimensions of quality of life that are strongly impacted following COVID-19 infection are usual activities and pain and discomfort. In terms of risk factors, so some COVID-19 symptoms are more associated with a decline in quality of life, such as general malaise, severe fatigue, muscle pain, and respiratory difficulty. And in terms of risk groups, women were more likely to have a decline in quality of life, individuals living with child or children, those not having at least one dose of COVID-19 vaccine, and individuals having a chronic respiratory disease before the infection. So one last result on change in quality of life and COVID-19 symptoms. So I decided to present the result of a decision tree for 2 reasons. First, because symptoms are rarely isolated. So an infectious disease often induces a combination of different symptoms, and it is this different combination that will influence patient outcome. And second, these different symptoms are strongly correlated with each other. For example, there is a strong correlation between having temperature and having chills. So we must take it into account. So here you can see in the tree, at the top of the tree in the first node, the whole sample with an average decrease of quality of life of minus 15. And then in the tree, the different combination of COVID-19 symptoms leading to different results in terms of change in quality of life. So on the left, you can see the combination leading to the lowest decrease in quality of life, so minus 7 points of quality of life for 941 individuals reporting no malaise, no tiredness, and no muscle pain. On the right, you can see the combination leading to the greatest decrease in quality of life, so minus 29 points for 245 individuals reporting malaise, chills, and loss of appetite. So in conclusion, some strength of the study, the potentially large cohort with 2-year longitudinal follow-up, and also the global approach of the long-term consequences of COVID-19 in terms of health, mental health, and social health. The limitations are, as previously explained, are the participation and selection bias with such a design, and also the differential loss to follow-up. In addition, we started collecting data 2 months ago, so currently no data are collected during an acute phase of the pandemic. The main challenge will be to maintain the cohort over time and the participation of individuals. And of course, more results to come with the first follow-up data. So thank you for your attention, and do not hesitate to contact our team. So you have our contact detail here in the slide.
Okay, perfect. Thanks a lot, Pierre. We have again some time for questions. So I'm looking at the chat box.
Maybe, Brett, I just want to, I cannot follow the total meeting, but maybe I just want to add that, in fact, part of the design was already planned at the time that the contact tracing started, but then that was put aside by practical reasons and also political reasons as such. So that's why you say that we don't have information from the beginning of the process, yes. But okay. And finally, very pleased that we are keeping pushing on that. We are able to do it.
Okay, thanks for this addition, Herman. I was maybe wondering, when would we be able to expect first results from the follow-up phase of the project? So of course we need some time for the actual follow-up and then also the compilation of the results. So would you have any indication of by when we would be able to expect some first results?
Yeah, so the study started 2 months ago, and we already have 3,000 participants. And the first follow-up for those participants will start in 1 month. So hopefully in early September or October, we will have follow-up data on those 3,000 participants. So we can start showing results of the first follow-up after 3 months. And every 3 months, we will try to analyze the data to update the result and post it on our website. Yeah.
Okay, perfect. Thanks a lot. Maybe one question from Nico. He's asking, what was the confidence interval on the 15% reduction in quality of life?
I think it was quite large. It's 20 points, I think. So for now, it's quite, we have a quite large confidence interval on the reduction in quality of life. Yeah.
Yeah. And does that mean that it would also include 0 in the interval?
No. So excuse me. I think it's 0.20 confidence interval. So I just check it. It's quite a small one. Yeah, 0.20. Yeah.
Okay, thanks a lot. All right, so then I suggest we move to the closure of this webinar. And to close the webinar, we have invited Anne-Lee, who is the spokeswoman and representative of the post-COVID community in Flanders. We've asked her to give some closing remarks and some insights that are, of course, relevant from the patient perspective. So, Anne, please feel free to take the floor.
Thank you very much. So hello, everybody. My name is Anne, and I'm the chairwoman of Post-COVID, the Flemish Patients Association for people with long COVID, and I'm very honored to speak to you today. My journey with COVID started with me getting sick in March 2020. I started to work again in April, but I wasn't fully recovered and had my first relapse at the end of May. I haven't been able to work since. I've tried several times, but my neurological symptoms are too severe. I need all of my cognitive capacities to do my job, so I have to be patient and wait until the dust, or in my case, the brain fog, settles. We live in confusing times, and it's even more confusing when you don't get better from what was supposed to be a bad case of the flu. I remember that around this time, a year ago, there were hardly any scientific papers on the subject, and I read anything that I could find. I even looked for articles on SARS and the Spanish flu because I needed more answers on what was happening to me and so many other people like me. That's why I'm very grateful to see how many scientists are doing their best to get these answers. And although there is still a lot to discover, it's good to know that we don't have to carry our burden by ourselves anymore. It is such a relief to find so many allies who stand by us. However, there are still some issues about long COVID that I would like to address today. The first one is about inclusion criteria. Although I understand why most researchers only include people who have a positive test and thus proof of their infection, I would like to ask them to broaden the scope of their research and also include people who have the same clusters of clinical symptoms but no positive test. The majority of people with long COVID don't have one, and it's creating an unnecessary divide between us. We need more studies that prove that a diagnosis based on clinical symptoms is sufficient. The second issue is about neurological symptoms. All too often, they are reduced to depression and anxiety. Yes, some people with long COVID do get depressed and are anxious, but it is not the majority of our group, and it's important to distinguish between primary and secondary symptoms. At this moment, for instance, there is insufficient work being done on objectifying and explaining the widespread complaints about brain fog. Because of this blind spot in COVID research, the highly prevalent neurological symptoms remain largely untreated and are all too often categorized as purely psychological in origin. I hope that scientists will look at this, for patients' increasingly frustrating blind spot, as a challenge to discover more about the human body instead of dismissing symptoms that don't fit pre-existing theories. As we've seen today, COVID is a multisystemic disease. People can develop diabetes, cardiac, respiratory, and so many more other problems. And it's important that we look at all these symptoms while looking for a cure for people with long COVID. Revalidation programs that only focus on one part of the body don't suffice, because it reduces our problems into separate symptoms, completely disregarding their interconnectedness. There is an urgent need for the development of a multidisciplinary care pathway for primary and secondary care to guide us through the labyrinth that is the Belgian healthcare system. And as I said before, we live in confusing times. And as long as we don't have all the answers about this atypical disease, it is more important than ever to involve us, the patients. We see the blind spots in current research and care approaches. We know what we need, and we know why certain things don't work. Research projects that really involve the patients have tangible knowledge advantages over projects that don't. We ask you to use our experiences, not only as patients, but also as people with certain areas of expertise. Because among the hundreds of thousands of Belgian long COVID patients, we have doctors, nurses, researchers, economists, politicians, and many of them want to help solve the mystery that is long COVID. A final point that I would like to make is about empathy and compassion. As patients, we draw confidence from events like today, focusing on new avenues of research geared towards finding answers to the many mysteries and challenges COVID-19 posed to humanity. But sadly enough, forward-thinking science and care are the exception to the rule in the daily life of long COVID patients. More often than not, our caregivers and daily environment is skeptical or even outright dismissive of our struggles, disbelieving our symptoms or reducing their origin to some type of depression instead of them being caused by a COVID infection. This culture of disbelief can at times be harder to deal with than the disease itself. It also leads to counterproductive care, glaring oversights in the research landscape along on top of conflicts with employers, friends, and family members. The battle against long COVID is hard and drawn out, and as long as the culture of disbelief persists, we undermine the efforts of patients to regain their former activity levels. That's why the most important thing you can do for patients is to believe us. Believe us when we say we had COVID, even if we don't have a positive test to prove it. Almost 2 out of 3 Belgian COVID patients never had a positive test. So please don't dismiss them, because their struggle isn't only with the disease, but also with the culture of disbelief. Believe us when we tell horror stories about certain caregivers, as those stories are a daily reality for many patients. A large group of caregivers still believe COVID is a lung disease that takes at most 4 weeks to recover from, and the way they treat their patients is often inexcusable. Believe us when we tell you about our symptoms, even if you can't find a cause at first sight. We often hear stories about symptoms being dismissed because they don't mesh with preconceived notions. This approach makes it impossible to discover the full scope of this disease. Believe us when we say that certain treatments, like graded exercise therapy, often have adverse effects in long haulers, even when some patients do benefit from it. Long COVID has different subcategories of patients, so a one-size-fits-all treatment just doesn't work. I could go on for a long time listing all the barriers patients face because of disbelief, but I won't, because there's a simple solution. Just believe the patient and use our expertise to help fight this disease. And stand by us, like you're doing today. Thank you very much for your time.
Yes, thank you, Anne, for these very powerful words and can only say that we fully support your call to involve patients fully and completely in these kind of projects. And hopefully with this webinar, we've been able to convey the message to all other researchers involved in post-COVID research in Belgium. So thank you very, very much for these words. And with this, I believe we can conclude our webinar. So I want to thank you all very much for being here with us today. A very special word of thanks to our speakers. We also look forward to seeing how these research activities will yield even further and more concrete and detailed results in the coming months and maybe even years. And we take with you the final words on that we shouldn't do this in our ivory tower, but that we should do this hand in hand with the people who we are studying or for whom we are doing the work. So thank you very much for this. And I wish you all a very nice afternoon. And I hope to see you in the future in one of our next webinars. So thank you very much and have a nice day.
Thank you very much. Bye-bye.